Okay, welcome back to Unit 6 recording, and hopefully this is the last one of this unit. We ended with absent seizures, which was a type of generalized seizure. Now we're going to get into the simple, or like the partial seizure, starting with the simple partial seizure. So a simple partial seizure is going to be an uncontrolled jerking movement of a finger, hand, foot, leg, face, or sometimes this will go unnoticed. It may spread to another area, and when this happens, that this is called a Jacksonian march. So, if it starts with one hand and then moves to the other hand, or starts with one leg, moves to the other leg, we call that a Jacksonian march. These may last 20, 30 minutes. People remain conscious. They may or may not notice it going on. They can also experience other things such as flashing lights, tingling sensations, or hallucinations. I have a friend that has seizures. She gets usually the grand, what we used to call grand mal. They're tonic-clonic now. And anyway, when she finally kind of got her medication figured out, she would get like her thumb would start twitching for like forever, like probably 20 or 30 minutes, just like it says here. And that's, that was a little seizure, partial seizure that was happening in her thumb. Kind of sucks, still, but better than having the full-on tonic-clonic seizure. Okay, complex partial seizures. These involve repetitive, non-purposeful actions such as lip smacking, wandering, patting, or picking at clothing, also called automatisms. These last less than 1 minute. They may have an altered level of consciousness with these. They may not remember having this or may be confused, and they may have an aura present prior to the activity happening. So this isn't the full-on tonic-clonic. This is a lesser form of that. It's usually on one side of the brain or the other, and but they can have that unconsciousness and amnesia with this one. Okay, status epilepticus. This is a continuous period of tonic-clonic seizures in which the client does not regain consciousness. Now, I kind of forgot to say that in this last recording, but we used to classify seizures like grand mal seizures, which were like the big ones. We call those tonic-clonic now. And so with status epilepticus, this is a continuous period of that tonic-clonic, of that really bad seizure in which the client does not regain consciousness. They will have physical exhaustion and respiratory distress. It is a life-threatening medical emergency, and we must do things to prevent permanent brain damage. This is triggered usually by an abrupt discontinuation of an anticonvulsant medication, an acute head injury, or a period of hypoxia. So what is happening in this is that you have the tonic-clonic, right? And you have to think that this is affecting all the muscles in the body, including that diaphragm, for respiratory maintenance. All those muscles, they're not functioning the way. So the person is pretty much not breathing while a tonic-clonic seizure is going on. They can also have a lot of secretions that they're having in the mouth. They can vomit during it. So we'll talk about some interventions coming up, but just know while somebody is in a seizure, they're not breathing. And so if you have one that's going on for like 5 minutes, you're like, oh crap, this person has not been breathing for 5 minutes. They'll also get cyanosis of their lips. That, that's a big indication to us that, okay, perfusion is a major problem. All right. So safety precautions. There's a lot of different safety things with seizures, especially that tonic-clonic. For safety, we want them to stay in bed, while they're having a seizure, side rails up, making sure those side rails are padded so that if they are having the tonic-clonic seizure, they're not injuring themselves. If they are out of bed, like they're going on their way to the bathroom and then they have this seizure, we want to carefully ease them to the floor. The idea is to minimize injury, moving nearby objects away, placing a soft item beneath their head, maintaining also, you got to think about your safety too. They have zero control over these muscle movements. So you've got to, kind of keep an eye on what's going on. No matter what, never leave the client alone during a seizure of any kind. Do not restrain them. Do not try to hold their wrists down or their legs down or anything like that. It's best to just let those muscles do what they're supposed to do. Very important. Do not put anything in their mouth. It used to be a thing where they would put different things in their mouth that was supposed to, so they wouldn't like cut their tongue off or they wouldn't damage their teeth. But they have found that this is actually creating much more safety issues than anything else. It's not actually helping at all. They had these bars they used to put in people's mouths. It was made out of the same material as bowling balls, and people were chomping those things in half. The only thing that we do put in their mouth, and it's, we use a lot of clinical judgment when we do something like this, but, if we have to suction, if they vomited or they're having a lot of those secretions coming out of their mouth, we don't want them aspirating that. So we will suction, but it's staying outside of the mouth as much as possible, because if they do chomp down on that tube, then, we could put them in more danger. Loosen restrictive clothing if they're wearing any. Turn head to the side so if they do vomit or have a lot of those secretions, that they can drain away. Monitor the activity. We're talking about timing, keeping track of how long they're going through this. And then, like I said, suction if needed. Medications. The goal of medication is to suppress neural activity. 3 general mechanisms of anti-seizure medications. They include stimulating an influx of chloride ions, delay influx of sodium, and delay influx of calcium. Acts like GABA neurotransmitters by stimulating an influx of chloride. Drugs may enhance this GABA release or block the reuptake of GABA. Barbiturates, the disadvantages, they are highly dependent in DNS depression, meaning people can get addicted to them very, very easily. Phenobarbital, effective for most seizures except for the absence kind. And benzodiazepines, these are very common. Clonazepam and diazepam may use for absence seizures with other medications as well. Okay, so here's a list of the most common ones. Your hydantoins. These desensitize the ability of sodium channels. As a result, there is a delay in the depolarization of the neuron, meaning it slows that action down, that chemical, or not chemical, but that electronic, or the electrical impulse. It's slowing that down from being transmitted, and so that hopefully these connections can figure themselves out before a seizure is caused by it. Ntoin or phenytoin are the 2 most common medications of these. These are effective for most except for absence seizures. They're the first line of drug for status epilepticus. Narrow range between therapeutic dose and toxic effects, so these people are monitored very closely. Phenytoin-like drugs, these are a drug of choice for tonic-clonic and partial seizures. Carbamazepine, these you want to watch for oral and skin hypersensitivity. The other most common one that I've seen given is this valproic acid. Oops, I didn't mean to really move that. Or Depakote. These are used for absent seizures as well. And then the succinimides, these are used for absent seizures. They suppress seizures by delaying an calcium influx into neurons. And then there's that type there. So I've got some just generalized seizure medication information down here in the notes. Aim to administer the lowest dose of a med with the least amount of side effects. So these medications come with all kinds of side effects and toxic levels. So we want to obviously administer the least amount without that's effective. Monitor serum levels of a lot of these. Valproic acid has a specific level that is drawn, and phenytoin has also a level that is drawn. May require a combination of drugs. They may require some and all of these. May need a lifelong treatment, and then assess for interactions with other drugs. Side effects can include rash, gum hyperplasia, where the gums kind of swell a little bit, blood dyscrasias, liver and kidney problems, toxic effects. We want to try to aim at giving these the same time every day. Do not discontinue abruptly, because that's what can cause a person to go in that status epilepticus. And monitor CBC, platelet count, and liver studies as needed. And there's a lot of other things to consider with these medications. Pregnancy, people that become pregnant, these we know will cause congenital defects. So then it's really a very important conversation for that patient to have with their doctor. Other treatments that I don't have listed here, and this is just for interesting facts, that friend I was talking about with the medications and the seizures, she actually went on to a seizure center in Kansas City and had half of her brain removed this last summer. I kid you not, half of her, she had a, I can't remember which side it was that she had removed, but I, been keeping in good contact with her, and she's doing amazing. She went from having 3 or 4 seizures a day, and then she got pregnant. So then she was off her medications and they got really bad. And then going back on the medications, they actually got worse somehow. And she hasn't been able to drive, because you can't drive if you've had a seizure. You have to wait 6 months, be seizure free for 6 months before you can get your license back. And so now she's just gotten her license back. She's been seizure free for for almost a year. It's kind of crazy. So anyway, just a little interesting fact there. That concludes this video, this recording. I am going to upload a couple of videos that I have saved here so that you guys can kind of see some of the seizure activity in action. All right, thanks.